Good afternoon to one and all. Myself, Muhammad Iftakar HJ. I'm currently a third year medico in HIMS Hassan. Today I'm going to discuss about an interesting case because the symptoms initially looked unrelated. We have seen an young patient came to the general medicine OPD with complaints of chronic bloody diarrhea. But that was not the only problem. Over time, he also started developing weight loss, joint pain, fatigue, and even redness of eyes. So, now the question is, what single disease can connect all these findings together? So, let's dive into this interesting case. This is a 28-year-old male who is presented to the OPD with the following complaints. His chief complaints are loose stools mixed with blood and mucus since 6 months, lower abdominal pain since 6 months, urgency during defecation since 4 months, fatigue since 3 months, loss of weight since 3 months, pain in both knee joints since 2 months, and the patient is also complaining of occasional redness of eyes since 2 months. And the duration of symptom is about 6 months, which are on and off in nature, and patient denies any history of recent travel, contaminated food intake, or similar illness in family. So we have done a physical examination in this patient, and these are the findings of physical examination. Patient appeared pale and mildly dehydrated, that is pallor is present. We have checked the vitals also, like the patient is having pulse rate of 102 beats per minute, blood pressure is about 110 by 70 mm of Hg, and patient is also having mild tenderness over left iliac fossa, and there is no palpable abdominal mass, there is no hepatosplenomegaly, and patient is having mild bilateral knee joint tenderness present, and perianal examination was normal. So overall, patient is hemodynamically stable, is having some signs of mild dehydration and anemia because pallor is present. So we have done some baseline investigations in this patient which revealed these findings. So hematological investigations like hemoglobin, which is decreased, which is on the lower side, that is 8.9 grams per deciliter. Total leukocyte count, it is slightly on the higher side, it is mildly elevated, which is about 12,800 per cubic millimeter. Platelet count is also on the higher side, which is increased, 4.5 lakhs per cubic millimeter. And inflammatory markers, that is C-reactive protein and ESR, that is erythrocyte sedimentation rate, both are on the higher side, both are elevated, so which suggests some chronic inflammatory processes going on in this patient. So we have done the stool examination. Occult blood test is positive. Pus cells are present in the stool, numerous pus cells are present in the stool, and RBCs are many, so they are present in the stools. And we have done the stool culture also, so thinking that it may be of infectious etiology, but on stool culture there is no pathogenic growth, indicating infectious etiology is unlikely. Some non-infectious etiology is responsible for this patient symptoms. And some baseline LFT, RFT, serum electrolytes we have done, which are all within the normal limits. And we have done the colonoscopy in this patient, which is showing a continuous inflammation from rectum to sigmoid colon, and friable mucosa with superficial ulcerations, which are suggestive of colitis and ongoing inflammatory changes, and there is loss of normal vascular pattern because of active colitis. So putting together these investigation findings and physical examination findings, we have considered some of the differential diagnosis in this patient. The differential diagnosis considered here are Crohn's disease, infectious colitis, irritable bowel syndrome, intestinal tuberculosis, amoebic colitis, colorectal carcinoma. So why we have considered Crohn's disease as a differential diagnosis here? Because Crohn's disease can also present with abdominal pain, diarrhea, weight loss and anemia, and it may also have extraintestinal manifestations like joint pain and eye involvement as this patient is having. But why we are ruling out Crohn's disease? Because symptoms predominantly involve colon only in this patient, and there are no small bowel symptoms severe pain, obstructive features are not present in this patient. And as we all know that Crohn's disease can involve any part of the gastrointestinal tract starting from mouth to anus, and it is basically patchy lesions are present in Crohn's disease. It is not continuous involvement. Then there are no skip lesions, there are no strictures, fistulas or perianal disease. Colonoscopy showed continuous inflammation starting from rectum, which I have already mentioned. And we have also considered infectious colitis because it can also present with bloody diarrhea and mucus, because some bacterial infections can also cause this like salmonella, shigella, campylobacter. But here it is very unlikely because symptoms are of chronic duration. Patient is having all these symptoms from 6 months, and there is no history of fever or recent travel, contaminated food intake, and stool culture we have done which doesn't show any pathogenic growth, stool ova parasite. We have done all those tests which are not in favor of infectious colitis. And we have considered irritable bowel syndrome because it can also present with chronic abdominal pain with altered bowel habits. But here the patient is having bloody diarrhea, which is not typical of irritable bowel syndrome, and patient is also having raised inflammatory markers, which is ESR, CRP are all elevated, which are suggesting some chronic inflammatory process is going on in this patient. And endoscopic evidence is also suggestive of some other pathology than this irritable bowel syndrome. So intestinal tuberculosis is also considered because it has to be considered in our tropical countries like India, and it can also present with abdominal pain, diarrhea, weight loss and anemia. Here it is unlikely because patient is not giving any history of fever, night sweats or chronic cough, and there is no ileocecal involvement or strictures or colonoscopy also. And amoebic colitis is also considered because it causes bloody diarrhea and abdominal pain, and it is endemic in many areas. So but here the stool for ova and parasite is negative. There are no liver abscesses or systemic features suggestive of amoebic colitis. And rather than all of these things, colonoscopy shows diffuse continuous colonic involvement but not patchy involvement, which is also ruling out the possibility of amoebic colitis in this patient. And colorectal carcinoma is considered because it can also present with altered bowel habits, blood in stool, weight loss, anemia. But here the patient is of younger age, 28 years of age, so colorectal carcinoma is unlikely in this patient. And here symptoms are chronic, and patient is having urgency and ongoing inflammation is there, and colonoscopy doesn't show any discrete mass or narrowing, which is also contradictory against colorectal carcinoma. So now if we put all the findings together, that is an young patient with chronic bloody diarrhea, urgency and abdominal pain, elevated inflammatory markers, continuous inflammation starting from rectum and involving the entire colon, and we have done the biopsy also, which is showing crypt abscesses, mucosal and submucosal inflammation, and it is also showing goblet cell depletion. So by considering all the findings, investigation findings and colon biopsy findings, and with extraintestinal manifestations that the patient is having, all these are pointing towards one diagnosis, that is one of the component of inflammatory bowel disease, that is called as ulcerative colitis. That is ulcerative colitis. And this ulcerative colitis primarily involves colonic mucosa in a continuous pattern beginning from rectum and extending proximally. Hence, it is also called as backwash ileitis. And patient is having bloody diarrhea because of mucosal ulceration and ongoing inflammation. Patient is having urgency and abdominal pain because of rectal involvement and active colitis component. Patient is having fatigue and weight loss secondary to inflammation and anemia. And patient is also having some of the extraintestinal manifestation like the knee joint pain, redness of the eyes. Here the knee joint pain is probably due to peripheral arthritis. Basically, ulcerative colitis is an immune mediated inflammatory disorder that is contributing to peripheral arthritis, which is resulting in knee joint pain in this patient. Redness of eyes may indicate episcleritis or uveitis, and ulcerative colitis can also be associated with other extraintestinal manifestations like peripherals, like primary sclerosing cholangitis, because both are showing P ANCA positivity, that is perinuclear anti-neutrophil cytoplasmic antibodies. Some patients can have skin manifestations like erythema nodosum, pyoderma gangrenosum also. So, this case is highlighting that ulcerative colitis is not merely a disease confined to colon, but it is a multi-system immune mediated inflammatory disorder with important extra intestinal manifestations like knee joint tenderness, redness of the eyes, primary sclerosing cholangitis, erythema nodosum, pyoderma gangrenosum, episcleritis or uveitis. So I hope that this clinical discussion or this clinical case discussion was a productive one. And for more and more such clinical case discussions and engaging clinical discussions, please share the video, subscribe the channel, and support the channel for more and more such meaningful clinical discussions.